Hello, everybody. Thank you for joining us. We've got another exciting interview here for the Journal of Immunotherapy and Precision Oncology. We've got Dr. Rebecca Harrison with us to talk to us about immunotherapy neurotoxicity. Dr. Harrison, thank you for joining us, and please introduce yourself to our listeners.
Great. Well, thank you so much, Dr. Jazieh, for the introduction, and to you and the JIPO team for the opportunity to do this talk. So I am currently a neuro-oncologist at BC Cancer, which is our provincial cancer agency in British Columbia, Canada.
Well, thank you so much for being here. We're excited to have you to talk to you about this important topic. So we'll get right into it. And the first thing we kind of want to know about is how important is it for clinicians who are caring for patients with cancer to know about these neurological adverse events of immunotherapy?
So I would say it's very important for neurologists seeing patients who have cancer, and then also for oncologists themselves, and really any clinician interfacing with the cancer population at this time. We know that these therapies have really revolutionized cancer treatment, and there are increasing and expanding indications for immunotherapies in oncology. And we also know the types of immunotherapies that are available to patients and are being approved are expanding as well. And so I would say with their increasing use, it becomes particularly important. And it's also very important because of the nature of the syndromes themselves. So we know that these syndromes can be associated with significant morbidity. They can also be associated with mortality. We know that they can have significant impacts in terms of the anti-cancer treatment that patients are receiving, whether it's interrupted, whether it's stopped completely. And so I would say overall, these, recognizing these syndromes and having an approach to these syndromes is very important for all of us that interface with patients with cancer.
Absolutely. And Dr. Harrison, can you tell us a little more about these syndromes and how they're distinct from what we see in patients who are not exposed to immunotherapy?
Yeah, so a lot of times we use the same names for the syndromes based on the clinical phenotype and some of the paraclinical testing that we get in these patients. But we know that they're actually somewhat different than the neurologic syndromes or the immune-mediated neurologic syndromes that we see outside the context of immunotherapy. So for instance, in terms of the presentations themselves, they can take on a really distinct phenotype. So in patients with myasthenia gravis associated with immunotherapy, we know that a significant proportion actually have concurrent myositis and may also have a myocarditis. And so it's routine to evaluate for both of these entities when you are diagnosing someone with immune checkpoint inhibitor associated myasthenia. So that's something different because it would be very unusual to see that combination in the natural world, but we certainly do see it in the context of immunotherapy related adverse events. In terms of other differences, so some of the paraclinical testing and data that we get is different. So for instance, in the context of AIDP or acute inflammatory demyelinating polyneuropathy, we know that the classic finding in the spinal fluid after a lumbar puncture is cytoalbuminol dissociation. So, an elevated protein in the absence of a leukocytosis. We can certainly see that when someone has an immunotherapy-related AIDP, but it's also not uncommon for us to see that they have both an elevated protein as well as an elevated white count in their spinal fluid. And so that's another sort of hint that there's a bit of a distinct biology in this particular population. And then finally, we know that the way we treat these patients is also different. So for instance, early institution of steroids or the institution of steroids is actually standard for these syndromes. However, we know that for some of these syndromes, when they happen outside the context of immunotherapy, we may or may not give steroids. So for instance, once again, with AIDP, usually we use intravenous immunoglobulin or IVIG or plasma exchange to treat these patients up front. And steroids really don't have a significant role in their treatment. However, when we see AIDP in the context of immune checkpoint inhibition, we will use steroids as an initial treatment in combination with, for instance, IVIG or Plex. And then sort of similarly, in patients with myasthenia gravis, we have different thresholds to use steroids in patients where it's associated with a checkpoint inhibitor as opposed to happening outside of that context. So it is important to be aware, I think, also of some of the distinctions of seeing these syndromes in this particular population.
That's very interesting, and like you said, kind of points to the differences in biology between these syndromes happening in immunotherapy and those happening in patients outside the context of immunotherapy. So, I mean, clearly early identification would be very important in these situations. And what are the early signs that you would recommend, people keep an eye out for, or worry about, or start to worry about neurotoxicity with immunotherapy in these patients?
Yeah, so I think in terms of the early signs, so they can be very varied just because there's so many different syndromes that can occur from immunotherapy, different neurologic syndromes, including, some that I think should be emphasized are shortness of breath. So in our patient population, when we, in certain cancer types, we might be thinking more of pulmonary embolism, for instance, when we hear shortness of breath. But I think in a patient on immunotherapy, also considering, could this be someone who has, myasthenia, myositis, myocarditis, and just having, sort of that on your mental roster when you're evaluating that patient and doing a clinical evaluation, considering those entities. And then I think being aware that, sometimes the symptoms initially can be subtle. So for instance, we have patients who present with ptosis or complaints of intermittent diplopia, and then they can progress, relatively rapidly to someone who has a more florid myasthenia presentation. So any sort of new cranial nerve findings, bulbar findings, new sensory motor, signs or symptoms. And I think just generally, including a routine neurologic examination as part of a clinical assessment of someone who's on these immunotherapies, and then just having a low threshold to do, a good clinical evaluation, neurologic evaluation in someone who has any new signs or symptoms that could point to one of these syndromes.
Excellent. And from your experience, what can help us kind of predict who's at risk of developing these syndromes? And of course, I think the big question always with these immunotherapy toxicities is, can we re-challenge them with immunotherapy, and who might, relapse into one of these toxicities? So would be great to hear what you have to say about that.
Yeah, so I think those are really big questions that have yet to be answered in terms of the risk of developing one of these syndromes. So a lot of patients that go on to develop a neurologic related immune adverse event, we haven't predicted, we haven't necessarily deemed them high risk. Of course, in patients who have a history of an autoimmune disorder affecting the nervous system, so for instance, if they have a history of multiple sclerosis, if they have a history of myasthenia gravis, then that's something that would certainly sort of, support, increased caution in using these therapies. But in terms of most of our patients, we really don't know. And I think that's where doing further exploration in terms of whether there is some latent, hereditary risk. Patients, do they have a family history of autoimmunity that might lend them to increased risk of these effects? I think is, important to further explore whether there's some alleles or genetic aberrations that can predispose patients. But I think that's somewhere where data is really lacking. It's a small proportion of patients that develop these syndromes, but they can be very disabling. And so it's worth exploring. In terms of the risk of re-challenging a patient with an immune-related therapy. So I think that's also an area where there can be some variability in terms of what's done and the comfort level with that. Oftentimes we're looking, so first of all, I will say as a neurologist, this is really a discourse with the oncologist. I think we're looking at, what has this treatment, or what do we expect this treatment to contribute to the patient's cancer care and control of the cancer itself. And that can influence the risk that's willing to be taken in terms of the treatment, and discourse with the patient around that is important. And then also looking at the severity and the grade of the syndrome that's experienced. So for some low grade syndromes where they're identified and they resolve with a treatment hold or with a brief course of immunosuppression, that may be an instance where a re-challenge is felt to be feasible and of reasonable risk, especially if the treatment is expected to be very beneficial to the patient. Whereas in patients with more severe syndromes, that might be thought to be an unacceptable risk.
Sure, for sure. Excellent. And I think, always when we talk about immunotherapy, CAR T cells is always another kind of very interesting point of therapy. And can you speak specifically about the neurotoxicity from CAR T cell therapy?
Yeah, so I think that's sort of a big topic in and of itself, and I would say increasingly, there's clinical trials evaluating new adoptive cell therapies and different forms of cell therapies, and then of course there's CAR T cell therapies, which also have expanding indications and are now incorporated in the standard of care in certain malignancies, especially hematologic malignancies. So in terms of the neurologic syndromes that can happen after CAR T cell therapy, so oftentimes, our biggest concern is them developing ICANS, or immune effector cell associated neurologic toxicity syndrome. And so this is a syndrome that we can see in these patients after they've received CAR T cell therapy. And this is a neurologic syndrome that's often comprised of some combination of encephalopathy, delirium, seizures, tremor, myoclonus. We often see it about 5 to 7 days after the treatment's been given, but we also, it's significantly variable. It can be several weeks after or sooner. And it may or may not be associated with cytokine release syndrome. And so it seems to be this distinct entity that in some patients can be really severe, can require the institution of steroids and other interventions to try and halt the immune response. And so this is something that we're increasingly aware of. Monitoring for these syndromes is part of routine clinical care for patients who have received a CAR T cell therapy, and also is incorporated as part of the routine monitoring required in the context of clinical trials. In terms of the management of the syndrome, so there are guidelines in terms of how to approach these syndromes clinically, and really what's recommended is that there's systematic monitoring of these patients after they receive an immune effector cell therapy, and that if they develop immune effector cell encephalopathy, or ICE, that they're, based on their ICE score and their other associated symptoms, for instance, do they have associated cytokine release syndrome, we develop a treatment plan for them.
Excellent, excellent. Great. So finally, and I think you've hinted at this already, Dr. Harrison, but what, in your opinion, what would you think are the steps that we need to take going forward as we study new immunotherapies?
So I think that, first of all, increasing clinical awareness is particularly important. So clinicians that are dealing with patients who have been exposed to immunotherapy, from primary care physicians, oncologists, neurologists, that they're aware of these syndromes and some of the differences of these syndromes in terms of their clinical presentations, as well as the therapeutic interventions, is particularly important. I think incorporating measures to evaluate for these neurotoxicities, as well as potentially biomarkers for neurologic toxicities in clinical trials of immunotherapies in different cancers, as well as different forms of immunotherapy that are being evaluated, is particularly important. And I think that this will also help us better understand, what are some of the risk factors for developing these syndromes and the relative frequency with which they occur with different immunotherapies. And then I think exploring different therapeutic interventions for these syndromes. One of the concerns that we have when we treat these syndromes is that oftentimes, the immunotherapy has been given to try and mount an immune response against the cancer, and we're treating these syndromes with immunosuppression, and sometimes it's fairly sustained and prolonged immunosuppression. And so are there therapeutic interventions that we can have that specifically target these neurologic syndromes that, may reduce the impact on the cancer itself, or the efficacy of the immunotherapy on the cancer. And then I think, as we mentioned earlier, better predicting who's going to develop these syndromes, being able to tell a patient what the relative risk is of developing it, and having that help make an informed decision about whether this is the appropriate therapeutic intervention, and using that information to facilitate monitoring patients, and imparting, risk mitigation strategies, I think would be a very important and meaningful step forward. And then I think also one area of importance and interest is, what are the long-term effects of these immunotherapies on patients? So I think with a lot of the neurologic syndromes that we discuss, we're discussing, pretty florid presentations. Patients are presenting with, an encephalopathy or encephalitis type picture, or myasthenia. And what we don't really have characterized is, are there sort of longer term or sort of smoldering effects in patients who have had these acute syndromes, and also in patients who haven't had these acute syndromes? So are there, long-term cognitive impacts of having immunotherapy? And are there, sort of long-term other neurologic impacts in patients who've been exposed to immunotherapy? And I think that's something that we really don't know. And I think really we warrant further longitudinal study to better understand the long-term impacts of these treatments on our patients.
Awesome. Thank you, Dr. Harrison. That was kind of all we had from our end. And we appreciate you coming and joining us on our channel to do this interview and to discuss this very important topic of neurological toxicities patients undergoing immunotherapy. Thank you again, and we really appreciate you joining us.
Great. Thank you so much for having me.
Absolutely.